afternoon, everyone. So I'm really thrilled to welcome you all to the second installment of our Health System Strengthening webinar series. Now, just to give you a brief context, this webinar series is part of Sambodhi's Center for Health Systems Research and Implementation, abbreviated as CHSRI. It is a new center which we have actually set up with a focus on building onto the existing body of research around health system strengthening, which is to further aid in evidence-based decision making within this space. Now, I'd like to formally introduce myself. My name is Jithin, and I'll be your moderator for today's session. Currently, I serve as a senior manager at Sambodhi, where I lead research initiatives focused on health system strengthening. To folks who have joined from outside Sambodhi, I'd also like to provide a brief introduction to Sambodhi as well. Sambodhi Research and Communication is essentially a research, measurement, science, and consulting service organization working in the development space, which is dedicated to generating high impact knowledge through data-driven insights and research. We have more than 18 years of experience and offer services such as monitoring and evaluation services, project management, and capacity building. Essentially, we help governments, donors, and development agencies to implement effective and evidence-based interventions. Our work largely spans across sectors such as public health, education, livelihoods, and WASH. Given this brief introduction, I would also want to kind of just briefly talk about the webinar that we have for you guys today. Like the title of today's webinar is Ayushman Bharat Digital Mission at the Forefront, which is catalyzing digital health transformation in India. Um, so in context of today's webinar, right, like we are actually looking forward to having some exciting and important conversations around digital health and with a primary focus on Ayushman Bharat Digital Mission and of course the health data and all that. As we all know and understand that digital health is transforming healthcare delivery globally, and India's efforts under the ABDM mission is actually paving the way for a more connected, efficient, and equitable health system. So today we are not just here to discuss ABDM in gen particular, but like we would also be exploring their real world implications, challenges that have been faced, and opportunities that it provides for improving health service delivery. And to do so, we have our esteemed panelists here who have like first-hand experience working in this requisite domain. And to be honest, we look forward to an like a really engaging conversation with them today. So before we dive into this conversation and explore how ABDM is advancing health systems through digital innovation, I would like to introduce our esteemed panelists. So first of all, we have Dr. Arundhathy Mamidi. It is my pleasure to introduce Dr. Arundhathy, a healthcare professional with over 22 years of rich experience in project and quality management. Her expertise lies in optimizing clinical and administrative operations to improve quality of care. Dr. Arundhati is actually renowned for her work in enhancing healthcare services through a comprehensive approach from preventive care to disease management, and is also known for her focus in improving service quality through implementation of automated systems like electronic medical records and hospital information systems. She has actually in the past collaborated with 200 healthcare professionals and doctors, successfully implementing clinical pathways and business processes to drive better clinical outcomes. Our second panelist that we have today is Dr. Nivedita, who is also my colleague from Sambodhi. Dr. Nivedita is a skilled healthcare professional and a dental surgeon with over 8 years of experience. As a digital health enthusiast, she plays a key role in evaluating innovative digital health solutions aimed at enhancing maternal and neonatal healthcare service delivery. Dr. Nivedita also oversees and also has worked on multiple data quality assessments for digital health portals, especially for Government of Gujarat, effectively contributing towards promoting accurate and effective use of health data and improving care. So basically, and like, thank you to both of the panelists here for joining us for this in discussion on Ayushman Bharat Digital Mission. And so I would like to kind of kickstart this conversation by actually posing a really, I think, a common question which all of us really have. And so probably we'll pose it to Dr. Arundhati so she can like start off the discussion. So, Dr. Arundhati, I wanted to understand, like, we've seen a remarkable shift in the way health data is utilized, right? And this is especially stark when you compare the pre-COVID and the post-COVID landscape, right? So, could you share your insights on how the Ayushman Bharat Digital Mission has transformed the health data space during this time? While talking about that, additionally, it would be helpful as well if you could shed light on the key components of Ayushman Bharat Digital Mission as well, and how these elements actually shape the future of healthcare delivery. Because I think that is a context that we all need to have first before we proceed with further discussion. So over to you, Dr. Arundhati. Yeah.
Thanks, Jithin. Thanks for a nice introduction. Uh, I think we have been working on health data for quite some time. It's not that we just started this journey post COVID. There's a lot of work happened in terms of capturing healthcare data, both at the hospital level, both at state government level and uh, national level in the form of registries. Uh, and then we had a lot of data which was driving health policies pre-COVID area also. But the only challenge that was that it was done by multiple people in multiple ways and lying in multiple locations and multiple places. And none of these databases talk to each other. They were all independent studies, independent activities, independent analysis done. And then there was no correlation of data done between these databases to understand exactly what is happening in healthcare data. And most of the data that we had was of operational and decision making data. Very few data sets we had from a clinical perspective in the pre-COVID area. But I think with the onset of COVID, the importance of clinical data has actually increased. And if we go back to National Health Policy of 2017, a complete chapter, chapter number 5, was dedicated for digital health transformation of India, where there was a vision that was put in to transform healthcare in a digital format, which is more in a paper format even today in most of the places. Now, let us take even if it is primary care or secondary care, a private hospital or a government hospital, most of the healthcare data is still in paper form, except a piece of data related to billing and registration, which is there in electronic form. Most of the data is in the paper form. But it is COVID which has actually triggered or enhanced or speeded up the whole concept of healthcare data digital transformation, even though we have been working before that, but it has really given that need to fasten it and create an impact, because it had showed that need for having healthcare data, especially the clinical data being around to manage patients in the post-COVID era. I think with that concept in place, then we had a mission called, initially it was called National Health Digital Mission, slowly converted into Ayushman Bharat Digital Health Mission, which is an organization in itself as a part of the healthcare system in India, as an independent department that was set up by Government of India as a part of Ministry of Family Welfare to support the integration and implementation of healthcare infrastructure to digitize healthcare. So this whole objective is to digitize healthcare data in place. Now, why do we need, or what are the objectives that we are looking at, is to create a data, because most of the data that we have today is on paper. We don't know what happens. There's no, even though we talk about care continuum or concept of care management across from womb to tomb, they're still on paper, because the data is not there for the patient from a patient perspective across his continuity of care. So the whole objective of ABDM was to create that setup, which will create the data available across the continuity of care, keeping patient at the center of the ecosystem. Earlier, the healthcare system in India is driven by providers. It is not driven by doctors, sorry, patients. Healthcare system in India still is driven by providers. But keeping patient, the whole objective or change in perspective that ABDM has got in is to keep patient first, or patient at the center, and rest of the stakeholders working on him revolve around the patient. That is the key objective, so that we get the data that is related to patient across, and patient has the complete data with him from whom to whom. So that is the reason why we wanted to work on developing the state-of-the-art digital health systems, create national registries, and create data sets for single source of truth. Just to give you an example, today, doctors, once we pass out of our medical uh, colleges, we register. Now, how do we register? We have to do registration at a central level, then we have to registration at every state level to practice. And it is not necessary that we have to close one to practice the other. So today we do not have one single source of truth, that the list of doctors that we have in the country, or list of healthcare practitioners we have in country, because it's all maintained at a state level, and one person can have registrations in multiple states. If they're working in multiple places or studied in multiple places, they will have multiple registration IDs across states. So we don't have a single source of truth of healthcare providers. Similarly, we don't have a list of hospitals. How many primary care centers that we have, how many secondary or tertiary care centers do we have today? We don't have that data in place today as a single source. Everybody publishes their own data, and there is no uniformity of data that is published. Similarly, list of pharmacies that we have, list of health workers we have. So one of the key objective of ABDM was to create the single source of data for all these healthcare professionals who are the key stakeholders for healthcare delivery system. Then create a personal health record to the patient. This is an objective to put patient first in the center, so that as a patient, irrespective of where I get care from, I have the data available with me, and I can share the data across healthcare providers based on my consent or a citizen consent. That's a concept which is a revolutionary concept in ABDM, where we have put the patient as the center. The other is the portability of data. Now, even though we have put in patient at the center, and we said that all of them, whichever hospital, see, for example, I go to a PHC, take some medication and some complications, I go to a secondary care center, goes and gets a surgery done there, and then go to a tertiary center, because there is no data connected all this. The data is unique, sitting in their own places. The reason, because the standards in which the data is taken is not same. Example, just to give, is like, how many of them know what a heart attack means? There's no common name for a heart attack, as simple as heart attack, or a common name for blood sugar, or hypertension, or ECG. Somebody says electrocardiograph, somebody says electrocardiogram, somebody says ECG, somebody says EKG. And then if you have to collate the data from all this into single one investigation, or single diagnosis, or single complaint, because these data sets are not interoperable, because they are not adhering to any standards. So one of the key objectives was to create those interoperability standards which are easily accessible to all healthcare professionals. And everybody is abiding to the standards along with the local nomenclature, so that we will not lose out on the local way of talking, but at the same time, at the back end, we have a data which is understood equally by anybody. Then how we actually send the data. One is availability of data in a unique format. The other is how we ensure we are actually sending. This is about your interoperability. What are the standards in which we are actually sharing the data across providers? Those are the major standards that were being incorporated as a part of the ABDM. Now, there are two key stakeholders as part of ABDM. One is the domain, that are the doctors and the providers. The second piece, your technology piece, right? Now, unless you really sync these two very well, put them together, knit them together in a fashion that actually gives you results, is the baseline for success of ABDM program. Because of which a list of principles have been created called as domain principles and technology principles. Let us spend a few minutes on the domain principles. One is the literacy of need for healthcare IT literacy, inclusive, universal inclusiveness, and ensuring we maintain, since healthcare is a very sensitive information, we ensure that security and privacy is maintained at the design level itself. At the same time, it needs to perform, make it accountable and portable, with the concept that we should know or have a vision of where we want to go and take one step at a time and accelerate fast. Now, those are the principles based on which the whole domain principles are laid down. And as we move forward, you can see how we have actually implemented them happening on ground for the last 3 years on ABDM implementation. And when it comes to technology principles, we were talking about healthcare data is so huge. You cannot put everything at one single place. And if you have to share any data, the type of data, data sharing, data content, and the source of data is the key. So unless for data sharing, there's a concept of technology principle of interoperability. There are standards that are developed for interoperability. And for data storage, the various building blocks have been created so that it is not there at one place, but at multiple places. And then if I have to implement standards, now, if you look at from a technology perspective, there are a lot of IT vendors who develop HMI systems or EMR systems, and they develop their own APIs to drive. But what happens? They become interoperable. They will not become interoperable. So we should have a common repository where all these APIs which are required for sharing the data are present at a central place, and where the sandbox was created, where all these open APIs were being developed and placed, so that all the technology vendors can use these APIs to develop their interoperability. And at the same time, we have already so many, more than 1,000 HMIs providers available in the country. No, we cannot ask them to shut down over a period and say, you use this. So we have to provide them a solution so that we leverage from the existing legacy and see that how we actually drive standards to that legacy systems. Make it very simple so that it is easy to use by the various stakeholders, and the data should be from one single source of truth, not from multiple places, but one place which will have all the data. Everybody pulls the data from there and then uses them for their requirements. The next slide, please. Now, if you look at various components of ABDM, the key components are your federated architecture, creation of building blocks, creation of standards, and then creation of governance structure and implementation module. We'll spend a minute on each of them, what exactly this means. Uh, let's just go to the next slide of federated architecture. Yeah. If you look at this federated architecture, which means that the complete data is not shared across and every data is available with the center or state. There are certain data sets that have been identified which will stay back with the hospital. Like, for example, billing data or data that is done for their regular work, like your vitals, your input-output charts from a clinical side, and your registration details will be regular data, but your admission, bed management, all these are data from operational data. So if you look at healthcare data is basically two categories. One is your operational data, the other is the clinical data. ABDM is focusing more on the clinical data and allowing hospitals to retain their operational data except for few data sets like your registration data, so that everything is being secured and provide confidence to the people at the ground level, saying that the government is not asking for every data that they want. The focus is more on the clinical data. Then there is a certain amount of data that is stored at a state level, like your reports or your registries or your public health data. How many cases of COVID was there in a particular area, how many cases of tuberculosis, how many emergency cases, how many RTAs have come across hospitals. This kind of summarized data is being there at a state level, because that will help them to take decisions related to implementing various healthcare reforms. Then you have a national level data which will help for health research, create national health programs, and also create a lot of reusable applications so that somebody can reuse and work on, and overall develop a health information exchange system. So national is only an enabler to create a national information exchange, just works on analytic piece of it to facilitate medical education and healthcare results, and also drive national health programs that are driven by the center. So the apprehension of doctors, one of the major apprehension when we spoke to people on ground for implementation was that once I have ABDM in place, all my data is public. No, it is not so. The data is not public. Only a certain amount of data or certain data types are being made available to states, and certain data types are available, certain data sets are being available at state. But most of the data is there with the hospital themselves. That is the whole concept of federated architecture, to build in confidence to the provider. And then let us look at various building blocks for each of them, how actually we have driven them. The next slide, please. If you look at these building blocks, first, if you look at, where do we store data? Do we store data at national centers, state level, national level, or the hospital level? And is it a localized storage system or a cloud-based system? So ABDM is recommending for a health cloud-based storage system with inbuilt security and privacy operation center, so that the data is secured and there is a health network that is created. And this infrastructure is enabled at a central level. Then you have created a lot of building blocks of data hubs. Like, for example, you're creating various registries. For example, every citizen of India is having their own unique health ID. Like we have an Aadhaar number today, which is an identifier for us wherever you go. We will have a unique health identifier which tags all our health records across various providers. So you develop a unique health identifier. That is again is your data hub that says, okay, these many citizens, so that we can build that application which actually contains the healthcare data of that patient, keeping patient as the focus. Then you have electronic health records, again at a hospital level where we maintain a health record of the patient that is given to them for an episode of care or across episodes of care for that patient. The other important data sets are your master registries. For example, you have multiple tests, right? Diagnostics. Today, without diagnostics, there's no healthcare system. How many of them call blood sugar as blood sugar? Somebody calls it serum glucose. Somebody calls it blood sugar. Somebody calls it fasting blood sugar, random blood sugar. There's no unique data dictionary there. Now, you need to create this master dictionary saying, but irrespective of somebody saying blood sugar, yes, it is serum glucose that is measured in the blood. Now, these health master directories actually help us to maintain these masters. Similarly, another simple example is your data that is maintained for your gender. In one application, they say male, female, unknown. Somebody stores it as 0, 1, 2. Somebody stores it as male, female, known, unknown, transgender. So there is no standard master data. That is your metadata of your data called gender. The metadata types are not same across applications today. Now, these health master directories actually help you to create that standard metadata sets so that everybody uses the same metadata so that the understanding level is same. So that we are comparing an apple to an apple, not to an orange. And somebody stores it as MFU. Somebody stores it fully. So if you are really pulling the data and then trying to analyze how many male patients, how many female patients across applications today, even that simple analysis is not possible because we don't have health master directories in place today, which is one of the major activity initiative that is done by the ABDM. Now, once we have these data hubs in place, then we are coming up with the concept called as a health locker where a patient can store all their healthcare data. We can anonymize the data based on the sensitivity of data, and sharing of data across providers is only driven through a concept called consent manager. So that only if the patient is willing to share the data that is given by provider 1 to provider 2, it is not provided to provider, but it is through the patient himself. Then the other is your healthcare analytics that is going to come in a big way. That's the happening thing across the world. Healthcare analytics is the buzzword that is happening everywhere. And then your GIS visualizations of pockets of disease-centric areas, and then creation of a health information exchange. Now, these are your technology building blocks. Over and above this technology comes your applications. You will have lot of EMR applications, HMIS applications, wellness applications, public health applications, emergency applications. Lot of applications get built over these building blocks by multiple vendors, and then they are delivered to patient by access, and delivery is given to the patient through PHR, a personal health record, which is nothing but My Health app, or India Health portal that will be giving the complete statistics at a state and a central level, the data that is shared in social media and across the call center, somebody taking the feedback forms, all through access and delivery. So these are the key building blocks that we are looking at as a part of building the ABDM compliance. Yeah, next slide, please. Now, with all these in place, the key data sets we started initiated with is your personal health identifier, nothing but unique health identifier of the patient, personal health record, health directories, and health data dictionary. These are the four important data hubs that we have already started working on. Lot of data dictionaries developed and published for using across various applications. We have a HFR registry done, HPI registry done, and patient registry already available. PHR app already available today for somebody to download and put the data, and consent management is already in place. Yeah. The next slide. Now, if you look at all these, then we're talking about so many things working out. Then how are we going to actually implement them on the ground? The concept of implementing all this is done using a concept called microsites or a microsite implementation, where the government of India have identified that we will come up with 100 microsites to start with, and then go around implementing or expanding them with the key objective of microsites being creating awareness for need for healthcare IT systems, especially for the key stakeholders on the ground. The four key stakeholders on the ground we should always keep in mind for any digital healthcare intervention is an ASHA worker, ANM, a doctor, and a nurse. So keeping these four people, the whole activity plan has been identified at a microsite for creating awareness, creating registries for them. We are registering all these people at the HFR. All these facilities we are coming under ABDM are registered under HFR. All healthcare workers are registered in HPR. And then they're identifying the applications that are required to serve the population of that particular microsite. For example, you have more chronic diseases at a particular microsite, so you should have an application which takes care of chronic disease management. If it is just maternity and childcare, then it should have an application which covers both chronic management and maternity and childcare. So identifying what are the services required at that particular service line and providing the technology applications for that is the key for successful implementation of any of the ABDM program. I think I'll stop here.
Thank
I
you,
think
Dr. Arundhati. I think that was a really good description of the Ayushman Bharat Digital Mission and the structures around it. But like you kind of mentioned a really pertinent point, right? Like regarding the lack of standardization in the master data sets itself, because therein lies a problem where discrepancies in data from different states or like even different areas within a state kind of come in. And these discrepancies can also be observed at a facility level, depending
yes,
on
yes,
the kind of experience the staff has. And as you highlighted really pertinently, like the key staff which are involved in data collection are the community health workers and doctors and nurses, and their understanding about the whole thing might be different from each other,
yes.
right? So this is exactly a great segue to the next point of discussion, which I wanted to touch base with Dr. Nivedita. So, Dr. Nivedita, as you kind of have worked on multiple studies related to data systems in Gujarat as well as in Rajasthan. So, I just wanted to kind of understand from your experiences from these studies, what are some of the key challenges you have observed at the field level, particularly when it comes to ensuring continuity of care in the context of ABDM? Because for continuity of care, we all understand the way we use the data. Like data also has a really major role to play in the provision of care and to ensure the continuity of care, right? So within this context, within the broader background of ABDM implementation, what are some of the key issues that we still face in terms of the on-ground implementation is what we would like to understand from your experience. So yeah, over to you, Nivedita.
Thank you so much, Jithin. So, as Dr. Arundhathy has already explained the ABDM infrastructure and how it works and what are the components. And it is an ambitious initiative which aim to, reform India's healthcare system using the digital health tools and technology. While it holds immense potential to enhance the healthcare delivery as well as the patient care outcome as well as the accessibility, but in implementation of ABDM itself, it is facing several challenges across various levels, across various states. So I'll be discussing some of these challenges also, which I have faced during my field experience in my studies. So here I'm discussing the challenges which I have divided basically in four levels: the governance, infrastructure, healthcare professionals, and the community. Coming to the governance level challenge, so as Arundhati ma'am was mentioning about the interoperability, which is a key to the ABDM, but interoperability in itself is a major challenge for achieving that ABDM objective. Why? Because at the governance in India, the nature of health system is decentralized and health is a state matter subject. So when it comes to these apps, when it comes to technology, when it comes to multiple systems, health information systems, so there are multiple systems which are running, out of which few are centralized health information system and few are the state led. So when you talk about interoperability, these systems are not talking to each other. There is no cross linkage. There is no communication between these multiple systems. So the data is not integrating. There is no patient information exchange between these multiple systems, which create a great challenge when it comes to decision making, when it comes to improving patient outcomes, when it comes to improve the quality of care. So, in my study as well, which we conducted across states, we also found that there are multiple systems which are running. But they are working in silos. They are not. There is no cross linkage between these systems, and the health professionals have suggested, they have recommended, they want, and they highlight there's a need that these systems should be streamlined into one single platform so that it will be easy, it will simplify the process as well as, and it will also help them, its usability will also increase. So this challenge is still there, which needs a lot of uh, focus from government as well as the stakeholders. The other challenge in the ABDM adoption is the limited involvement of the private sector. So recently, Government of India has published a report on completion of 3 years of ABDM that 1.3 lakh facilities are being ABDM enabled. Out of those, 17,000 were the private facilities. So from this data, we can still see that the participation of the private sector is very limited. It is still very low. Now, there are many reasons why private facilities are not opting, why they are not adopting the ABDM. So, most of, we are not talking the high level, the big uh, hospitals or healthcare settings of private sector, but especially the small and mid-sized establishments. they either lack the awareness about the ABDM. They are not aware what is ABDM, how it will function, how it is beneficial for them, how their patient care and accessibility will improve. There is a lack of awareness. And also, if they are aware, but they are showing minimal interest because there is no incentive or there is no money tied up to these such kind of implementation, these digital interventions. Now, there are also one reason where government is, this is one of the major reason which Dr. Arundhati has already discussed about the microsites. So government has initiated 100 microsites project to address the challenges, the ABDM adoption challenges which these small and mid-sized scale private facilities are facing. Now, since the government and the private sector, they are not communicating. There is a huge gap between the government data and the private sector. So if they are not seeking, suppose for instance, a patient is coming and seeking care in a public healthcare facility, and if it is a long-term intervention, then patient is registered in the public health facility, but in middle they may opt out and seek facilities from the private care. Now, in this case, there is a disrupt. There is no continuum of care has been broken in between. You cannot track those patients who have left the public health system and went to the private. So, for that continuum of care has been broken for such patients, and it is very difficult to track their health outcomes or to have any kind of follow up with them since both of these systems are not interacting with each other. Here, interoperability will definitely play a major role. Once it is established, it will make a huge difference in overall care management. Coming to the health professionals level, now, as Dr. Arundhati said, that whenever these digital interventions are implemented or when they are planned, it should be to simplify the lives of the users, the healthcare providers, rather than adding any kind of complexity. So whatever systems we are designing, it should be to ease, not to hinder their daily operation. But the major issue which our Indian healthcare system is facing is the lack of adequate human resources, which is a significant barrier in overall health system, but also when it comes to adoption of these digital interventions, because they are already burdened with their clinical duties, multiple data entry systems already running, and then introducing a digital system or digital initiative without phasing out from the legacy processes which are already running, it will increase the burden and strain to those healthcare professionals. And this challenge was highlighted in our studies as well, where the facility staff, where the community staff is definitely facing a burden. They face the increased workload due to the management of multiple data entry systems, where parallelly they are running the information system, different portals, along with there is a dual burden because they also have to do the manage the paper-based format. So it is a duplication of effort that is happening, and there, which is why it is burdening their daily operation. The second uh, challenge which healthcare professionals are facing is the digital literacy. The digital literacy among the healthcare professionals is still low, especially if you talk about the frontline workers, the community health workers. They are facing a digital literacy challenge. They are not aware of how to use those facilities. They are not tech savvy in using such technology. So this underscores the importance that they need a regular training, they need hand holding, and they need refresher courses regularly to utilize these digital technologies. So as I was saying in our study as well, we have faced all these challenges. Now, one of our study which I conducted with ECHO, where they use a telementoring platform for capacity building, we faced a major issue why there is a low participation, because the community health workers are facing this issue lack of technical knowledge and skills to use any digital platform, which is not only affecting their participation but also their overall learning is affected by this. So they have a platform to use, but they don't know how to use, then how it will be effective. The other challenge is the transition from the traditional healthcare practices to transitioning to digital solutions. It requires not only training, but it is a cultural shift. It requires a huge behavioral change in especially the doctors. So traditionally, doctors are used to write a prescription manually. Now, if in a transition phase, if you will ask a doctor to switch to a digital device, they might resist because there is a behavioral shift is required to change their practices. So convincing them to adopt these new practices along with ongoing busy schedule, clinical duties, clinical responsibilities, daily operations is a big challenge. Coming to the next level where I will talk about the infrastructure challenges. As Arundhati ma'am has clearly mentioned the role of infrastructure in any digital intervention and how infrastructure of ABDM is functioning. So, in line to that, I'll just say that ABDM implementation require adequate infrastructure. Any digital intervention requires the infrastructure, the readiness to adopt that intervention. So, however, in our country, there are many regions, especially the rural area, which like 65% of our population resides in, they lack robust IT networks. They lack the secure data storage facilities, which is a major issue because, for instance, in one of our studies, the healthcare providers reported that frequent connectivity issues during their ongoing processes and during their delivery of healthcare, it made it challenging to connect IoT devices which they were using to measure the health parameters with the digital application. So it is leading to delay the real-time data entry, hence delaying the overall objective of prompt decision making, which is required for the patient for improved health outcomes. So just due to connectivity issue, which is a major issue, most of the evaluation studies conducted, this is a major issue coming that internet and connectivity is a major problem to use these digital technology or digital portals. Other issue is also the financial burden, which is associated with digitizing healthcare facilities. So it is a challenge. Why it is a challenge? Because especially for smaller hospitals, they may face it as a significant challenge because they need to invest a lot to adopt or to transform their operations from manual to digital. They need to invest a lot, and there is no funding or there are some financial burdens because of which they hesitate to adopt these technologies. And also there is, as we said, that there is a lack of awareness. They don't understand the ABDM functioning. They don't understand how it works, and they don't understand that it is a one-time investment which they can make. But still, financial resources are a major issue. Coming to the community challenges, again, one of the major challenges is the lack of digital literacy. There are people who are not familiar with the digital health platforms. They are not available. They are not aware of the mobile application, and they need adequate training. They need support so that they can navigate around the system effectively. So this is a major issue which require a major focus of key stakeholders as well as government. Now, there are also issues related to demographic groups. So, when we say the lot of patients are not digitally illiterate, but there is a demographic group specific to senior citizens and women who might this barrier more due to their limited digital literacy, access to technology, or they don't even have the smartphones or they don't know how to use the smartphone. This results in what we called as intervention generated inequality. So, like, there are some initiatives, even well intended ones, can work better for some group of people who are well aware of that initiative. For instance, in this, so the digital technology work well for those people who are tech savvy and they know how to use it. But when it comes to such demographic groups, it is a challenge then. Then, third is the awareness regarding ABDM's functionalities and advantages. Even a community is not aware of what ABDM is, what benefits it is providing to the general population. They are not aware of. Patients are unaware of how to obtain their Aadhaar cards, how to obtain their Aadhaar number, how to use the digital health services to avail services, those services. So these are all the challenges which are hampering the successful implementation of ABDM, and we need to address these challenges at the multiple level and at governance, professional, infrastructure, community, and it requires a collaborative efforts between government, the private players, the local communities, the healthcare providers. So it has to be a collaborative effort to overcome these barriers. Thank you.
Thank you, Nivedita. Like, I think you are very right in terms of pointing out that the challenges that we face in terms of the ABDM implementation is multi-layered. And generally, we have seen in India, like, the strategy of one size fits all usually doesn't work. So, along with this multi-layered challenges, we also need multi-layered solutions as well, which is context driven and like which is like really indigenous to the specific areas that we are addressing, right? So this is where I probably would like to come back to Dr. Arundhathy's experience, like leverage her experience in understanding, like, ma'am, given this multi-dimensionality and the layered aspects of these challenges, so and given the complexity in implementing like or like solutions to solve for these challenges in a country like India, like what according to you could be the potential way forward to kind of mitigate mitigate such issues, and like, what do you think would potentially be a good strategy to like address these challenges? Because as we all know, one of the things that you discussed in the beginning of this webinar was, the challenge of standardizing everything. So in that context, there is a challenge of even like standardizing the kind of challenges that we are seeing. So, with this kind of requires a multi-layered solution as well. So, how do we go about mitigating this is what I am really interested in understanding now.
I think first thing we need to understand this. First, we have to understand the stakeholders. What is their stakeholders' mindset today? Unless we understand those key stakeholders and their mindset, whatever solutions that we create are not going to work. Now, who are the key stakeholders for us for implementation? As I already said, it is the ANM, the ASHA worker, the nurse who's providing service at the bedside of the patient, and the doctor who's the decision maker and the person who actually drives care. And what kind of data that we are looking at. In my experience, I had spoken to a lot of doctors about ABDM implementation and especially in the private setup. If Nivedita was mentioning that the acceptability of ABDM in a private setup is still very low. Now, we try to understand why it is low. Why is that a doctor in a private sector is more apprehensive than a doctor in a public sector? And when we try to analyze the solutions or when we try to speak to them, they have so many apprehensions in their mind. Saying that, okay, if I do implementation of ABDM, I am made public. All my activities are known to public. I will not have anything with me. Now, if you still see the way the kind of patient categories or patient types that we have in India today, 50% of patients or 45 to 50% of the patients are still cash patients. The rest of them are either paid by private insurance or government insurance scheme or company-based insurance schemes based on the companies that they're working. But still 40 to 50% of them are still cash patients. And most of this data of cash patients is not available anywhere because they will come under various vigilance operations. So most of them are scared key. Now if I implement ABDM, government is policing me. Why should I be policed for the work I'm doing? Now, these are the questions that people have asked us when we started working on training or educating people or creating awareness on ABDM. One thing we have to explicitly tell them that the focus of ABDM is not on the operational data. As I told you, the complete data of healthcare data is divided into clinical and operational data. ABDM focus is more on the clinical data for continuity of care to the patient. The focus is not on the billing data. The focus of ABDM is not on the billing data. It is about identifying the right people and see whether the right treatment is given to them at the right time, and see that we optimize the care by not duplicating the services or not providing the services that the patient is required to be provided. That is the whole objective of ABDM or whole objective of digitization per se. Digitization objective is not to have an eye on the billing data. And that is the awareness that we need to create in the providers. Now, unless we do that, then that apprehension will come up. The second major apprehension I saw in them is, I already have so many patients to work. I don't have time to digitize. The most first answer I get the moment you talk about digital health is saying, I already have so much work to do. I don't have time to work on digital systems. I cannot see my patients if I'm working digitally. Now, the solution is provide confidence to physicians, provide confidence to nursing team that digitization will reduce their workload and not increase their workload. Literally, I'll just give you an example where I literally, create people confidence. One of the strategies that we developed is that we made one doctor fill the case sheet in a paper format, and another doctor fill the same case sheet for the same patient in an electronic format, in their own words. So to show them that actually filling the case sheet in an electronic format takes much less time than filling the case sheet in a paper format. And any paper, and also tell them that if you're filling them in an electronic format, you can always retrieve. Whereas the data in paper format is not retrievable. We literally showed them saying that, okay, both of you, we will say that doing this, you will actually reduce time, not increase, because we are giving you these facilities. You will have a pre-medication structure already present. One click will give you 7 medicines already prescribed for this patient earlier. So for all the continuity medicines, you don't have to rewrite or type. It will just go and you just have to add and delete medication. And then we create profiles of investigations so that it becomes easy for them to prescribe, not write them, each of them independently. So we have to give them a confidence that actually using the digital health will reduce the patient time and they can focus more on patient care rather than documentation. If we are able to give that confidence and give them the solutions which will enable this, ABDM implementation becomes a cakewalk. But today focus is more on gathering data. Let us understand what these 4 stakeholders need to make it, and then drive the whole thing in a standardized format for them. Is a single point solution for me to drive ABDM at the community level or a private sector level. Give them a confidence that you're not being policed, you are just sharing the data to enable patient care. Give them the confidence. Today, somebody might ask me, then why are we driving? Today, we are driving ABDM through PMJY. And PMJY is a government billing system. So why are we driving? Let me very clearly tell you that government is using PMJY as a driving source and not to get the data of billing data into ABDM, but as a driving methodology to implement ABDM. Like the way we have done for NABH. If you people understand, when NABH has started, it was voluntary completely, and then say whoever is interested can go for NABH accreditation, which showcases the quality of care that is provided in the hospital. There were very few people who were taking over this program. Then they came out with a proposal saying, okay, we say that if the hospital is NABH accreditation, the insurance, they will get 2% extra if the hospital is NABH accredited, so that we ensure the quality of care given to the patient. Then a lot of people started entering into NABH accreditation system, where they just used, NABH has used insurance management system as a driver to drive quality services in healthcare. Similarly, ABDM is using PMJY as a driver to implement digital health in India. And if that is being very clearly told to the people or make them aware and give them the right solutions that they want. If you look at various solutions that are available today, we have multiple solutions. Even if you look at ABDM compliant solutions, we have around 70, 80 ABDM compliant solutions available in the market. But then if you look at them, all of them are, somebody is taking care of only emergency, somebody is taking care of OP, somebody is taking care of IP, somebody is taking care of only pharmacy. Now, if they're talking to each other, they're not talking to multiple applications. Again, if you burden them to work with, that will become your challenge. So you should look at an organization level or at a microsite implementation level, identifying the solution, the right solutions to the required community. What kind of IT solutions we need based on what are the kind of services that we need in that particular community is the key answer for providing the right solution. We don't have to do multiple. Today, if you look at ANMs, I felt very sorry for them when I really went and did a study for them. They were entering the same data across 8 or 9 applications today. Each patient data is entered in 7 to 9 applications. Obviously, there will be reluctance because we are overworking, because we are not looking at them, their work. Already they are overburdened. We are already having shortage of nurses across, and we are overburdening them. We have to come out with solutions which actually important. And then when we are talking about providing, once you have a digital based, today, how are we paying? If you look at PMJY payment is based on services that they provided by the doctor. It's not mapped to outcomes, because we don't have data on outcomes. Once the ABDM is implemented, we can drive outcome-based payment systems, which will actually trigger quality of service that is provided to the patient at the ground level. So one of the objectives is that. So understand the needs on the ground, identify the right solution, remove the apprehensions, and take it forward. And there is no one solution which fits everybody.
Yes. Thank you, Dr. Arundhati. So, given that we are close to time in order to conclude, so basically, I just want to kind of have a quick question to Nivedita. So, basically, we spoke about microsites, right? So, it is essentially like examples of how, like case studies of how ABDM is being implemented in different areas. So, I just wanted to understand like these different microsites that are functioning across the country that we see, how do we, what's the way of assessing or measuring or monitoring how these are being implemented? Are there any like specific guidelines or implementation tools that one can use specific to ABDM to like measure or monitor ABDM implementation is something that also wanted to kind of understand. So Nivedita, if like yeah, like your inputs on those would be helpful.
Sure, Jitin. So as you were mentioning the how if it is there any guideline to monitor or implement the ABDM. So there is no specific guideline or tool to implement or assess the readiness for the ABDM, but there are many tools globally which are used, which can be used for the assessing the of health system for readiness, for assessing their maturity, and then how we can plan the digital strategies. So as Arundhati ma'am rightly said, there is no one size fits for all solution. And digital transformation is a dynamic journey that varies based on the what is existing infrastructure we have, what resources are available, and what is the digital maturity state of that particular organization, or if you're talking about microsite. So before doing any assessment, we need to assess all these four categories, like who are, what is the vision, first of all, why we want this digital transformation. Then any digital strategies need digital literacy. You need to develop, you need to build that capacities around that digital technology usage. Then what is the healthcare infrastructure which is available and which might need to introduce that digital technology? Who all the key stakeholders who will play to implement this digital strategy or intervention? Then how, what digital tools like application is required, the platforms are required, IoT devices are required, whatever apps, whatever technology we are finalizing, will that technology will match with the services provided by that particular facility? That also has to be taken care of. So when we see digital maturity of health system, it should be assessed before we plan any digital implementation. We have to assess that the health system is ready to adopt any digital intervention or not, because the maturity level scores tell us if it is a low level maturity, then the opportunities for investment and leapfrogging enhances. Whereas if the high level maturity scores are there, then that suggests that the readiness is of facility to adopt more advanced or disruptive intervention. So coming to the ADB digital health readiness assessment, which is before any transition, before any introduction to that digital interaction. This is the readiness assessment tool which ADB has proposed. It assesses the readiness on four grounds, that is the core readiness, the technological readiness, learning readiness, and the societal readiness. So in core readiness, they try to understand the need assessment of that particular, what is the vision, why it is needed. So that need assessment is done. What is the level of comfort and trust to use those technology? How the system is planning to adopt the key aspects for that planning, and appropriateness of that technology for the existing users and existing services. Technological readiness, they see the availability and affordability of the technology for that particular health facility. What all hardware and software needs are there for adopting that digital intervention. Physical access to the technology and capacity building. Learning readiness is the existing program and resources to provide that training to the healthcare provider to use these technology. Then inclusion of healthcare providers also during planning stage, during the planning process for any implementation of digital interventions. And the last one is the societal readiness, where we see how there is an interaction of one organization with the other institution or organization in the society. It is relevant or not, and what socio-cultural factors should be taken care during this implementation. Okay, yeah. So next is digital health assessment tool, which is given by the World Bank. This is a digital health readiness tool. So it is divided into three mechanisms which they use. So first they see the digital health landscape profile. So in this profile, there are some around 50 indicators they use, which are grouped in 5 domains: the socio-demographic profile, digital environment, infrastructure, communication, intervention and application, and the workforce. So based on the landscape profile, they go to the next mechanism, which is the digital health maturity score, which is again assessed on 4 areas, which is digital ecosystem and governance, architecture and data, application and analytics. And the third mechanism they use is the in-depth interviews, just to also connect the primary data to understand more in-depth about the topics which are covered during these assessments. Yeah. And this is specifically to both private as well as the public sectors. The NABH Digital Health Standards, which is launched in 2023, and it is designed basically to assess the hospitals on their digital maturity and integration of technology in healthcare. So this standard use around 8 chapters and 182 objective elements, and the maturity level is assessed in 4 categories: the core, commitment, achievement, and excellence. So the core is it is mandatory for all. The objective elements comes under core are the mandatory for all. Commitment reflect to commitment to digital health standards of NABH. Achievement is they are representing some kind of higher maturity and quality. And then excellence are those hospitals which are demonstrating exceptional performance. So as I mentioned, there are 8 chapters and 182 objective elements. So these are few assessment parameters which they use, like the EMR integration, how electronic documentation of the patient records will be done, the HIS implementation, how hospital information system will be used for patient registration, for appointment, for admission, discharge, feedback, etc. Then telemedicine, interoperability to ensure that the system is communicating, the departments inside the system are communicating. Data security and privacy, and technological infrastructure, the hardware, software, and trained, skilled healthcare workforce to use these digital health uh, technology. So these are few tools which we can assess the digital health readiness and maturity.
Thank you, Nivedita. And I think this basically concludes the major discussion points that we had with respect to this webinar. However, I like there are like a few concluding sentences that I want to mention based on the discussion that we just had. And as the audience must have already understood that the discussion that we had around ABDM and its federated structures and like the challenges and mitigation strategies and various tools that we could use to monitor like ABDM implementation is like a certain it's just one aspect of ABDM, right? There are other aspects related to data protection, privacy, the laws around it and all that we didn't discuss naturally because of paucity of time. But this is something that I wanted to inform the audience that we are actually considering hosting a webinar about that in the coming future. And before I present the concluding statements, like I just also wanted to kind of inform the attendees here that since this is the second webinar of among the health system series that we have initiated, there are more webinars to look forward to in the coming months. We are timing it on a monthly basis, and keep a lookout for on our LinkedIn page for like future webinars, so that you are updated about the time and the day when these webinars would be held. Now, based on what we just discussed, as we wrap up our conversation today, I basically want to leave you with a key thought. Again, I think these are some points that Dr. Arundhati kind of emphasized on. We basically essentially heard about the challenges and strategies to mitigate the challenges around ABDM. But one thing is like that was really clear is that in order to for this initiative to truly succeed, we need to make the life really easy for the people on the ground, like especially the community health workers, doctors and nurses, right? Like this is the base from which or basically I would say they are the foundations to make ensuring that ABDM succeeds. So they are the ones basically implementing the digital systems daily, and their workload shouldn't increase because of it. So um, I feel the focus needs to be on simplifying the tasks so they can spend more time on patient care, not paperwork. As like there was an example that Dr. Arundhati mentioned, right? And while we move forward with these new technologies, I feel we should keep their experiences, like the community health workers and doctors and nurses, their experiences at the forefront. If we do that, I personally feel that ABDM has the potential to transform healthcare in India. And I also like like based on what Dr. Nivedita just mentioned about the various tools that could be potentially used to measure implementation, ABDM implementation. I really also hope that the research community actually does more research into this and like kind of generates evidence on how ABDM is being implemented across microsites in India. And probably we really look forward to reading those kind of research. And so now I'd like to open the floor for questions or thoughts from our audience. Like we have 15 minutes left. It will be a sharp, hard stop at 4:30. In order for the attendees to ask questions, they should raise their hands, and our host here, Shraddha, would actually unmute them and allow them to speak. So yes, like so I think the floor is on for the attendees, I guess. Now you could go ahead with your questions.
Jithin, I think we have one in the chat present saying NABH outcome-based financing is a driver for institutional. See, NABH is for institutional care. NABH is not developed for OP care. NABH is more for inpatient care. PMJY is also more for inpatient care. Then we don't have an insurance mechanism system for outpatient care as of now. But as a part of ABDM, yes, we are asking the individual providers to be compliant to them. And based on their outcomes and the number of cases that they're digitizing, there is some kind of incentivization that is being discussed on, but nothing came on paper, black and white today. But since the number of individual practitioners are quite a number, and there is a discussion happening in that front, how do we actually incentivize individual practitioners? And then we will get to know the whole system very soon.
Thanks. Can you hear me?
Yes, Vikas.
Yeah, thanks a lot for really an insightful presentation on the ABDM. Like, means I have a comment and I have a question to ask. My comment is more around like often we have as healthcare practitioners, researchers, we've looked at technology as a solution. I think some of the points that the panelists made, it's pretty clear that technology and the digital mission surrounding it is an enabler towards bringing towards healthcare. So I think we should always remember that is what I walk away a lot with from this presentation. But my question is, and both the panelists actually alluded to it in terms of sometimes calling it as culture, sometimes calling it as need of the hour, in terms of changing behaviors at the level of the people who are going to implement. I just wanted to know from the panelist, has there any behavior change intervention or like, that kind of things being implemented at scale in India, which are moving towards trying to change the behavior of healthcare professionals towards digitizing or towards enabling their facilities to adopt ABDM structures, or like, moving away from more paper-based registries and things like that? Do you know of any? And if yes, which are they and what have their experiences been? Thank you.
Doctors are the most difficult persons to change. I hope you understand that. Most difficult persons, any person whose maximum resistance to change is given by doctors than anybody else.
I completely agree. Being a doctor myself, ma'am, I completely agree.
So I'm a doctor myself, so I know what it means. And managing a doctor is the most difficult thing. And there were instances where just people when we went for digitization, throw papers on my face, saying, I don't need this, you please get lost. But at the same time, when I'm making this, if you explain them the way it actually works, understand their concerns, address them, once they change, they will not go back. Now, this is my experience in last almost 20 plus years I've been working in this space. I must have interacted with more than 200 plus professionals, healthcare doctors working in. But understand their apprehensions first. There are a lot of apprehensions with doctors, saying they will take more time, my eye-to-eye contact to the patient is reduced. So do you expect me to look at system or look at patient when the patient comes to? So what do you expect me to do? Understand their apprehensions, address their apprehensions. We should never say that when you're talking to the patient, look at the system. Or if you look at the way the doctor prescribes, he'll never write on paper when he's talking to the patient. He completes discussion with the patient and then he writes. So as you're writing, the way you're writing on paper, just use this. Or when I'm going, now today what happens, why EMR is a big failure across the world is because you are not documenting any digital health at point of care. We are asking them to document it post happening of care. Now, that is duplication of work for them. When the doctor goes for rounds, let them, instead of carrying a medical record, carry a tab. The nurse carries the tab, opens the patient data at the bedside of the patient and explains the patient case. And he sees all the reports. What does doctor do at the bedside of the patient? If you understand that, explain how it is enabled in the system and how it will help. Understand their apprehensions and work. Once they change, they stick with you for a lifetime. But that changeover, we need to be patient enough to explain their apprehensions. Again, most of them are worried about their billing systems. One important information that we have put them is that ABDM is not focusing on their billing data. ABDM is focusing on clinical data. Then they are comfortable, or you're giving them a sign of relief. Did I answer your question?
Yes, ma'am. Thank you so much.
Yeah,
I'll just ask I think a follow-up question to what I had posted in the chat on. I mean, we do know, and Arundhathy, you did mention that India is both Nivedita and you mentioned that India is more of standalone practitioners than it is an Apollo or a Medanta.
Yes.
So in that scenario, when there are 80% to 90% of the people are standalone practitioners, what is the way forward for ABDM? What would really work for them to report data? Would it be regulation in a country where basically Clinical Establishment Act has not been really has not really taken off, and most of the private practitioners are still under Shops and Establishments Act only?
So don't position this as a reporting tool at all first to individual practitioners. We should never position them that this digital health initiative is not a reporting tool. It is a tool for them to maintain their patient's data so that when the patient visits the next time, he has the complete data with him readily available. Drive these individual practitioners that way, then things will become easy. Reporting will happen as a byproduct. Convince them saying that you are keeping the data for your patients. So when they come, you already know the condition status for which you come. That will actually make the patient very happy, and doctor calls the patient the moment he says, okay, you had this, how are you? Is your pain reduced? Already, are you still continuing the medications? Is this medication stopped or not? You will actually make those personal statements by looking at the record of the patient, makes doctor-patient interaction better. Position your whole initiative for in that way. Then automatically it becomes easy. One of the solutions I could think of was to make that easy for them. This I have experimented in an inpatient setting, outpatient setting in a hospital though, which has worked very well. But at the same time, I'm feeling this is something which we can use even in a room-based clinic, saying that it has all this patient data to increase their interaction with the patient. Yes, when the patient comes in, the patient is already registered with you. So the person standing outside creates that registration number, and when the patient comes inside to see the doctor already has that patient data in place, and then he communicates with him in a more personalized way. I think that's the way to drive digital health for single providers.
Yeah, I think one more solution can be the regulatory compliance, which is missing. It can be a powerful motivator when something that government mandates that, it is a human nature to oblige by those compliances. So that can also be a solution if we make it a mandate that they have to use the digital documentation, electronic telehealth, all these things. If they become mandatory, then I think the adoption might get improved.
Thank you all for joining this webinar. We truly appreciate it. And as I mentioned, do look forward to these monthly webinars that we would be hosting. So yeah, thank you everyone, and look forward to seeing you again in another webinar. Thank you.